Uh, so I have a few people to thank and a few announcements before we get started. So you can see the people who have endorsed this on your screen. Thanks to all those organizations. Also, we have some financial support from Medtronic and Boston Scientific. Thank you to those sponsors. And really, one of the main people without whom this cannot happen is my administrative assistant, Hannah. And Hannah's here running things behind the scenes. Thank you to her. I want to thank today's experts, Dr. Aziz and Dr. Makanta. Dr. Aziz will be giving the didactic at the end of the day today. Very much want to thank Dr. Asma Chowdhury from Pakistan, from Multan in Pakistan, for agreeing to present a case. As you know, if you're regular to this program, I've been asking for people to put up their hand and volunteer to present cases. And so thank you, Dr. Chowdhury, for agreeing to do that. And most of all, I want to thank the audience for coming and participating enthusiastically. Please send all your questions, comments, whatever you have through the chat feature. If you want to speak, please cut in and speak as well. Should not be a problem. And a few announcements. Next month's program will be the last Friday. I think it's the 24th of June, if I'm not wrong. We have another very, very interesting case lined up for that day. So please try and join. Hannah will be sending out a survey. Please do take it and try and answer your questions. And most importantly, if you have any interesting cases you want to present, even simple cases, it doesn't matter. The most important thing is to have a good, few good ECGs to show so that people can learn from them. Anyway, with all that said, let's get started. So we will go to Dr. Chowdhury's presentation, which will be shared just now. Anna, please, can you share the presentation? Thank you so much. Dr. Chowdhury, please go ahead.
Thank you everyone for having me here. This is a case about an 8-year-old boy who presented to us with a history of sudden collapse while he was attending school. And at that time, bradycardia was noted, so he was referred to a cardiac center. Previously, he had 2 similar episodes of fainting and vomiting, and he was managed in a general pediatric hospital emergency. And there was no history, there's no ECG available previously. He had no remarkable family history. And during this episode, there was no history of fever, cough, diarrhea, etc. He had bradycardia, therefore he presented in emergency. Later on, his echocardiography was done and it was normal, showing normal functions, and heart was structurally also normal.
Okay. Dr. Chowdhury, can I stop you for a second?
Yes.
Okay. Sorry, I'll keep interrupting you because I want to bring in the experts and ask them for their comments. So anything more you want to know, experts? Dr. Makanta.
Yeah, it's always important to know, what exactly the person was doing. I mean, syncope is extremely common, and the majority of syncopal events are really not heart rhythm related directly. So some of the main historical things that can lead you in any direction would be, obviously, exercise is a big red flag, and during the middle of exercise sometimes needs to be distinguished from immediately after exercise, with during exercise being kind of much worse. And then also, you can think of postural changes. We'll often ask what time of day it was or what they had eaten or drank before that. So the majority of syncope is in the history.
Thank you. Dr. Chowdhury, do you know if he was exercising or running around in the school when he passed out, or was he sitting in the classroom?
Oh, he was actually sitting in the classroom. There was no physical activity involved at that time.
I'm also intrigued by this story of vomiting. Was it before he fainted or after he fainted? When he woke up?
This was the past history as described by the parents. So when he presented this time, he was kind of drowsy, irritable, And so, and
Anything
ECG shows.
else with Dr. Aziz, Pete?
I think I know where you're headed with the vomiting question, Balaji. I think when we hear vomiting, I think this entire presentation, at least on surface, somebody at rest passed out and had 2 episodes a month ago with fainting and vomiting. You know, vomiting obviously is a big vagal stimulus. So if somebody vomited, to Balaji's point, and fainted afterwards, that wouldn't be too much of a surprise or a concern. So digging into those details is really important. It sounds like we're going to be hearing a bit more about this patient, but there's certainly nothing on this page that screams at us as a red flag.
So basically that's all in the past history, and it's very important, as Dr. Chowdhury has pointed out, the family history. What are the things that we should be asking in family history when we have an 8-year-old that passed out? Any thoughts? Any of you experts?
You know, I always directly ask, or almost always start with, just any unexplained death in any family member. So oftentimes they won't, you know, if you ask about sudden cardiac death or whatnot, they don't exactly know what that is. But then if you just say, you know, did somebody die, and we have no explanation. Other things would be like a single car accident, can also be a way that somebody in the family died suddenly.
Is anybody dying in a sort of a bizarre death, unusual deaths? I also ask about people who drowned, people who know how to swim, who nevertheless drowned while swimming, things like that, or seizures. As we know, long QT, the traditional, I think the first few cases of long QT that were described were initially thought to have seizure disorder. So that's another thing. Anyway, Dr. Chowdhury, go ahead. Let's go to the next slide. Are you there, Dr. Chowdhury?
Yes, this was the ECG at presentation.
This was in the emergency room?
Yeah, this was in the emergency room, and it's not a 12-lead ECG, but this is what we have.
Very good. No, this is fine. It's nice to see real life stuff, because this is better than some of the quality of ambulance stuff that we get. Pete, go ahead. Give your thoughts.
So now this changes everything, because what smelled like maybe it could have been benign on the first presentation slide, seeing this, obviously, the first thing, there's lots to unpack here. There's a lot going on in the CCG. So the first thing, obviously, is from a rhythm standpoint. My arrows probably don't show up on your screen, but you see P waves with no ventricular activity associated with it. And then on the third beat, you see 1-to-1 conduction. And then the next 2, there's no QRS after, and on the third. So it looks like there's probably a P wave in the T here too, just marching everything out. So it looks like every fourth beat has a QRS that comes after it. So there's clearly not 1-to-1 AV conduction. And then you wonder, are those fourth P waves really associated with that QRS, or is this totally dissociated? The relevance of that, you could argue, but nevertheless, as electrophysiologists, we always want to know if there's any association here or whether it's clearly dissociated. And it looks to me, if you look at all these conducted beats, that the PR interval is relatively the same. So that could suggest that there is some conduction there. The other thing that's sort of interesting is that, that you could sort of hint at the fact that there might be a slurring of the initial portion of the QRS, at least in the middle and the lower lead. And that would suggest WPW. I almost don't want to even talk about that, because I have a feeling that has nothing to do with this. But if you just showed me one of these QRSs, I would say, hey, that looks like a wolf. I think in the context of this being heart block, then that is off the table, because you would expect there to be conduction down a pathway with these other beats. So I think that's off the table. And the other thing, I think the most bizarre thing about this is that these QRSs look very abnormal. So you would expect in somebody with an escape rhythm and either to be junctional or ventricular. And if it's junctional, the QRSs are nice and narrow, just like a sinus conducted QRS would be. Or if it's a ventricular escape, the QRS would be wide. What we see here looks like a lot of ST segment depression. And in the context of an 8-year-old previously healthy boy that's having syncope, the first question here is this an acute myocarditis? And of course, you shared the information that this happened a month ago. Maybe it's true to unrelated, that what he had a month ago was vagal, what he has now is myocarditis. Maybe this was always myocarditis, and perhaps we missed it in initial presentation. You'd expect some of this to resolve. But certainly this raises a lot more questions than I think answers at this point.
Tony, any other thoughts?
Not really. I mean, I think Pete summed it up that, the key thing is sometimes I break down ECGs very basically, and too fast or too slow. This is too slow. Wide or narrow, that's a little odd on this one, but I think it's wide. And then you see more than one unconducted P wave. So there definitely is high grade heart block, be it third or I guess second degree type 2.
So the sinus rate seems to be, or the atrial rate, I should say. I don't know for sure this is sinus, but we can assume this is sinus. The sinus rate seems to be around 120. The ventricular rate is around 30. So this is severely bradycardic. I presume this child is sitting there, not looking well in the emergency room while this is being taken. Let me ask the two of you, could this be just that this kid is vagal? Or do you think there is something fundamentally wrong with his AV node right now?
Yeah, I mean, I think if you got the story that the patient was vomiting and we got this rhythm strip, you could probably invoke that theoretically. But I think the morphology of these QRSs suggests that there's definitely pathology going on.
Yeah.
Even if we saw one-to-one conduction and you saw these QRS morphologies, you would still say something very abnormal is happening. So no, and when people vagal, just for the trainees out there, you'll oftentimes see very long pauses or long runs of transient heart block. It takes quite a bit to make somebody lose consciousness. We don't always capture that on tracings, but when you do, it makes everybody concerned, and it tends to be sort of an alarmist trigger. Having said that, this tracing is alarmist for different reasons.
Anything you want to add, Tony?
Yeah, usually also when people vagal, it does affect the sinus node as well. So, unless this was like head.
So, yeah, that's a very great point and a very important point. If you see that the sinus rate is also really slow and you have AV block, so both of the main parts of the conduction system are simultaneously affected, that would be more in favor of a vagal mechanism. If it's, here the sinus seems to be appropriate to maybe slightly tachycardic rate for this child, but there is AV block. So that would be more in favor of a AV node problem. And given the history we have, we are suspicious of an acute problem like myocarditis, as Pete nicely said. Next slide, please. Okay, here is the question slide. Now that we've discussed it, audience can participate. Hannah, if you don't mind. What is this rhythm? Atrial flutter with 4-to-1 conduction, complete heart block, high grade but not complete heart block, and I don't know. Yeah, thank you. Okay, so there is one person who thought this was atrial flutter. Anybody? Pete, do you want to say whether this is atrial flutter and could it fit in with that diagnosis?
Yeah, I think, you and Tony brought up the atrial rate, and the atrial rate at 120 is maybe a little high for an 8-year-old. I think in the context of this being perhaps myocarditis, I don't know how surprising that is. It might just be some underlying sinus tachycardia. I think for atrial flutter in a patient, as we saw with a normal echocardiogram, you would expect, very clear flutter waves with no isoelectric segments in between. the atrial activity. So I would be surprised. If this was a 40-year-old Fontan patient, then maybe those are flutter waves, but that's not
Yeah.
the history we're getting.
So great point. So atrial flutter in people with normal hearts usually has rates in the atrium like 300 or above. So that would not fit in with it. Next slide, please. So we are saying this is either complete heart block or high grade heart block, not quite complete. Oh, this is an interesting slide. Go ahead, Dr. Chaudhary.
So in emergency, temporary pacemaker was implanted through right jugular vein. And this is the tracing after temporary pacemaker.
Okay, so can you give us more details? Was the child cooperative? Did you sedate the child? How did you put the IJ line in to get the temporary pacemaker? Was it done in the cath lab or was it just done in the emergency room, etc.?
It was done in the emergency room, and the child was already drowsy and unconscious. So it was difficult to plan the procedure. So it was done in emergency room.
Very good. And obviously, most emergency rooms don't carry temporary pacing equipment.
Our hospital is a pediatric and adult cardiac center. So we have in emergency, we share emergency with adult cardiac people. So
Great.
we have temporary pacing equipment in the
Equipment
emergency.
there.
So it's
Excellent.
available.
Excellent. Any thoughts on this slide, Pete or Tony? Or this methodology? So we have a child who's what it looks like sounds moribund, unconscious, having passed out, looks obviously bad. And if it was possible to do this without sedating the child, that itself tells you how sick the child was. Any other thoughts?
First of all, it looks like you're capturing, which is good. And
Can you explain what you mean by that word, capturing? I think for people, some of the people here may not have done this before or may not have dealt much with pacemakers. What all do you see on this slide?
So you see a pacer spike, so kind of a high, high frequency or narrow, very narrow spike. And then you see the QRS following that every time on here that I see. So you don't see one, you do not see one spike that doesn't capture. And what that means, when you put in a pacing lead, there's a certain amount of energy that it will take to basically capture or make the myocardium beat. And that has to do with how much energy you dial up through the pacing lead, but also just the lead's interface with the heart itself and even the lead's location. So wherever this lead is, it's making the heart beat. It's the bottom line. And I imagine that Dr. Chaudhary and her colleagues were breathed a little sigh of relief when they got this in and got capture. And I imagine that there was an improved pulse or a pulse after this.
So looks like you're pacing at a rate of, what is it? 75? Something like that?
Yes, 75 to 80.
Yeah. So as soon as you did this, did the child immediately wake up or?
Can I just add one other thing?
Yeah,
Raj?
please.
So I think Tony's point about capture is a good one. That's usually the first thing that we look at is the thing working. The other thing that strikes me as bizarre, and I just can't, my eyes cannot stop focusing on this, is when we pace ventricular myocardium, you would expect the QRS to prolong for sure, because you're not using the normal His-Brooke energy system and conduction through myocardium is delayed. But that's not quite what we see here. We see QRS prolongation in the initial probably quarter of the complex, but the rest of it is probably still all ST segment elevation.
Yeah.
So teasing out what might be difficult, but this is definitely not what a PACE QRS usually looks like. Some of the other things that we dissect as electrophysiology doctors is what is the morphology of the QRS complex in terms of its access. This is always a check for us. So when we're in the lab, when we implant a pacemaker, we want to know what the PACE QRS morphology looks like, just in the way of where is this lead, and is that lead in a place where you wanted it to be? Is it the RV apex? Is it at the septal wall? Is it the RVOT? Is it on the left side, which obviously is not what you want? And I've certainly seen that before. It can sneak through a PFO and get rid of the left side, or it could be in the coronary sinus. So all those things, I think, as implanters, we're a bit mindful of. We do pay attention to what the QRS looks like.
Yeah, I mean, this is at least in my experience, this is a very rare thing that you have to do in the emergency room. I've only done it once in my entire career so far. And, you know, based on what I've heard so far from Dr. Chowdhury, this case is very reminiscent of the one I had. These questions that you're asking are really good questions, but questions for a little bit later, maybe. At first, you just want to get some pacing going and stabilize this child. So here's a child who's moribund and, you know, very bradycardic. Do either of you use transcutaneous pacing? Experts?
We'll touch on that in a little bit. I think the transcutaneous pacing is like the Neanderthal approach. Like, you know, if you're like stuck in a cave, you don't have anything else but the machine, I suppose that's what you can use, but there's much more elegant ways to get somebody's heart rate up, either mechanically or with medications. Transcutaneous pacing hurts a lot. And for the most part, it's not something you would need to do, at least not for more than 30 seconds or something like that. I have never used transcutaneous pacing. I've never, you know, found the opportunity to do that. Usually, we'll talk about this in a bit, but usually there are other ways to be able to get somebody's heart rates up that are much more patient friendly.
So transcutaneous pacing, I think has a role in a very limited setting. In this child, possibly because the child was moribund or almost unconscious, because it is very painful. Through the defibrillator machine, we can do that. This is a sort of a quite provocative question I'm just going to ask, because I'm wondering if people are not asking many questions in the chat feature just now today. Please go ahead and ask if you have any questions. What about transesophageal pacing? Tony.
So we do use that. It's a good option. And basically, if you have intact AV conduction. So transesophageal pacing, you essentially are pacing the posterior left atrium. And so for sinus bradycardia or, you know, other other conditions, postoperative sinus bradycardia with intact AV conduction, it's not a bad option. It's also a great way to, if you want to overdrive pace something, if you have someone in SVT and you want to pace their atrium really short bursts at like 300 or 400 to get them out of it. But if you don't have AV conduction, you won't cause a ventricular contraction.
Very good. Thank you. Thank you for clarifying that. Next slide, please. Dr. Chowdhury.
So clinically, patient was improved. He was conscious, fully conscious, and he was stable. His clinic vitals were stable. Heart rate was stabilized between 7 and 75 beats. He was his blood pressure was normal, and he was clinically improved. He was up and about next day. And while pacing was not even when pacing was not being he was not being paced, his heart rate was 70 to 75 beats per minute. And he was kept under observation, and temporary pacing was stopped.
Wow.
Then,
That's very interesting that he made such a dramatic recovery. Was he being treated with
24
anything
hours.
while he made his recovery?
No, he was just being, he was kept under observation.
So you,
Nothing, no antiarrhythmic drug was given, or nothing was given to increase the heart rate.
so,
This was an
say,
observation next day after
what,
almost 18 hours.
what was your working diagnosis at this point in terms of what was underlying cause of this heart block?
It was surprising, as we were working, we made a diagnosis of complete heart block on the basis of initial ECG. And we were planning for the permanent pacemaker implantation, but the child, but his heart rate improved. And his
Yeah, this is,
his echocardiography was done, and there was no evidence of myocarditis. His functions were normal. There was no dilated, dysfunctioning heart. Heart was normal structurally, and functions were also normal. So he was,
Yeah, go ahead, Pete.
Yeah, a couple comments, and Balaji, I want to hear what you have to say too. A couple things that you want to know is, what does the ECG look like when the heart rate's 70 or 75 now that conduction is recovered? Is it 1-to-1? Is it Peter long? Is there a bundle branch block? Are we still seeing the ST segment changes we had seen before? And I'd like to hear what everybody else thinks about this, but in my opinion, an echocardiogram doesn't rule out myocarditis. It may rule out myocardial dysfunction. But myocarditis really is inflammation more than it is an echo diagnosis. So you really want to know if there was a troponin leak, if there was other inflammatory markers that were up that would suggest myocarditis. And somebody like this who has very, very dense and a low escape, and all of a sudden it comes back, this transient nature of this makes you really wonder whether it was a transient process, whether it was something that was infectious or inflammatory.
Yeah. Yeah, I agree. Myocarditis would be top of my list of differentials. Tony, do you have anything to add?
Well, I guess just, we said the heart rate came back, but did conduction come back? I mean, is this still, ventricular escape or junctional escape rhythm with the rate of 70?
Great point. So, he could be at a atrial rate of, say, 150 with 2-to-1 block, and the ventricular rate could be 75. So I think getting another ECG would be very, very important. There's a few good comments on the chat feature. One question is, can we give isoprenaline, some kind of a chronotropic agent? Any thoughts? Before the experts weigh in, I would say yes, in an emergency, yes, but isoprenaline can be a two-edged sword. It also makes the heart pretty irritable. And if you have a heart that is being affected by myocarditis, it has to be very carefully watched. These patients can go into ventricular fibrillation at the drop of a hat. So you have to, while you're treating the bradycardia, you want to be very, very careful. I think it's a good emergency measure. What thoughts do you have, Tony, on that, or Pete?
Yeah, I think it's worth it to try and raise the ventricular rate, but it usually does drop your blood pressure as well too. So that's another thing to worry about.
Yeah, I have nothing else to add about the estradiol, but again, I think it comes down to what are we treating, right? What is the underlying cause of this? And that really is going to guide not just your acute management, but your management the day, the next day, the day after, and throughout the hospitalization.
I think Dr. Savli has commented. I think he or she has had a similar case. So the one case that I had was proven myocarditis. We proved it with the biopsy after stabilizing the patient and treated the child with steroids, made a really good recovery, needed pacing for about, 4 or 5 days. And about a week to 10 days later from the time of admission, walked out of the hospital without a permanent pacemaker because the conduction returned. So these are extremely rare, but this is a very, very interesting case that you were able to stop the pacing after 24 hours. Let's try the next slide. Okay, this is the ECG. Okay, Pete.
This is the ECG without pacemaker, without pacing.
Yeah, thank
Yeah, it
you.
looks like our suspicions here are confirmed a bit. So the first is, what's the rhythm? We see 1-to-1, looks like it's sinus. So there's a P wave up in 1 and up in AVF. So the origin of the activation of the atrium is depolarizing in the right vector. And 1-to-1 in that there's a P before every QRS and a QRS after every P, so it's sinus. What's not normal, of course, is there's the left axis deviation. The QRS is probably a little on the wider end. It's not that obvious, but a little wider than it should be for a guy his age. Then there's clear ST segment changes. So in 2, there's depression, AVR, there's elevation. The left precordial leads, particularly V4, is very profound ST segment depression. This all still, to me, looks like, myocarditis picture.
Tony, anything to add?
Not really. I agree. Just the ST
Yeah.
segments are very concerning.
The
And
ST
your T
segments are very
waves are-
concerning.
Your
T
T
waves are
inverted and
bizarre.
one AVL, and then the precordial leads to suggest that the myocardium is not happy. Sorry, Balaji, go ahead.
No. This is the myocardium is not happy. There's right bundle branch block and there's left axis deviation. So there's bifascicular block. So the left posterior fascicle is the main one that's working. I don't know if it's a complete right bundle. Maybe there is some element of right bundle branch block. AVR looks very bizarre with this infarction type pattern. I think this still looks like myocarditis, some kind of an acute myocardial insult. And given the age of this child, and the story, etc., myocarditis would still be top of the list. Is there another slide? Next slide. So there's a question about PR interval. The PR interval seems short. "48 hours without pacing, still the same ST segment depression, very bizarre repolarization patterns. Conduction seems to have returned." So there are various questions from the audience. Did you do any CRP, troponins? Was the patient febrile? What was the echo like right now? Did it look like the child has any myocardial dysfunction now at this point? Dr. Chowdhury, anything that you can help us with?
We didn't go for troponin levels, and CRP was it was within the range 6 or less than 6, I guess. It was unremarkable, and we could not document any dysfunction. And viral markers are not available. We don't have that facility.
Okay,
Or
you don't
bio-
have the ability to do viral stuff. That's okay. But still, given how bizarre everything looks, it's very interesting that you have a normal echo with all this going on on the ECG. Any other thoughts, experts?
Did you ever get acid, blood gas, or how
Yeah, blood
acidic
gases.
was this kid at its worst point?
Did the child look really sick at this point about 48 hours, or was he looking all right? His blood pressure is okay. He's acting like a normal
was
kid. He's
all-
talking, mentating.
He was all right talking, and his blood pressure was normal. He was all right.
Wow. Wow. And you never use steroids or IVIG or anything like that. There's a question about that.
No, we didn't consider myocarditis, or we didn't give him any steroids or IV immunoglobulins.
Wow. Very, very interesting case. Kind of goes against a lot of the things that I thought about acute myocarditis and acute heart block. If it's not myocarditis, what else could it be?
So yeah, it still could be, I guess, evolving myocardial infarction, or I would be thinking of the coronaries, either a coronary anomaly or even active coronary thrombosis.
Were you able to see the coronary arteries by the echo? Were you able to see the origins of the left and right coronary arteries, Dr. Chaudhary?
Yes, we did look for the coronary arteries origin. LCA was normally originating.
And no
And,
aneurysms, like no suspicion
no,
of
there was none.
Kawasaki's. Is kind of
No
old
Kawasaki.
Kawasaki's disease.
Could it
I mean,
be related to COVID infections also?
sorry, did you think it was COVID?
I'm now thinking out loudly relating to the Kawasaki that can it be associated with that?
There are certainly reports of acute heart block with COVID. There was a case report a few months back. Yeah, MISC, multi-system inflammatory disease after COVID. There's been a few cases reported of complete heart block with that. I mean, we don't know enough to be able to say that this was not COVID. So was there a COVID test done? Do you know?
No COVID testing was done in this patient.
Okay, but there was no other features of COVID. His lungs were okay. There was no other thromboembolic phenomena anywhere else.
He had no respiratory symptoms.
Very, very interesting. Yeah, that's definitely a possibility. Next
Also,
slide.
if it's associated with COVID, it has to be in the past history.
Well,
Respiratory symptoms would have been in the past history.
He was sick about a month before.
He had history of some kind of illness.
Some kind of an illness, potentially a viral illness about a month prior. It's a very interesting story. I don't know that I've ever heard or seen a story like this. Have anybody in the audience seen something like this with COVID? Anybody have any experience you can share with us?
So we did have a case, and I think we did get it published within the last year, that was MISC, that kind of presented as an evolving heart block, and we did have to do temporary pacing through the IJ, but just for about 24 hours. We did have the positive COVID antibodies and other evidence of COVID for that case, and the conduction did resolve. But the T waves and everything were not abnormal like this. Yeah. So
what was the acute phase reactant CRP ESR in your case?
Very high. I can't remember how high, but it was clear that an inflammatory
Extremely
process
high.
was going on.
Yeah, that sort of thing stands out in this case. I would have expected the CRP to be very high, given all the findings we have here. I'm also thinking, are there any poisons that can do this? Could this child have been exposed to something, some kind of a toxin, some kind? Anybody have any experience with that?
I've not seen digitalis toxicity, though. Dig toxicity can cause just about anything.
Mm-hmm.
So I'm sure that would be in the differential, at least for something like this.
Yeah, but the recovery within 24 hours would not go with that. We had a case of dig toxicity that was so severe that the child actually needed ECMO for a while, for a few days to recover from that. Question, can tricyclic antidepressants cause this kind of picture? My first reaction is no, because the QT looks okay. The QT would be very prolonged in tricyclic antidepressant toxicity. Have you, any of you seen a tricyclic antidepressant toxicity? Anybody?
Yeah, it's QTC prolongation.
Yeah.
I haven't seen ventricular arrhythmias as a result, but I've definitely seen
Yeah.
QTC prolongation.
I've seen a few in the sense that, you know, I'm usually reading ECGs and I come across an ECG with a very wide QRS. And I think to myself, oh my God, this is a new prolonged QT. And I'm thinking, oh my God, this is a new long QT patient. And I go to the patient's chart and I look and I see, oh, this was done in the emergency room. The patient was seen for a tricyclic overdose, etc. So that's how we pick that up. Anyway, next slide, please. Is there another slide to follow this? Okay. Dr. Chowdhury.
So he was kept under observation, and because PPM is not easily available, it has to be arranged in our setup. So he was in the hospital for a few days, and while he was in the hospital, he was his heart rate was between 75 and 80 beats per minute, and he was otherwise acting normally. But we consulted with our electrophysiologist, and he suggested that permanent pacemaker should be implanted. So the pacemaker was arranged, and while the pacemaker was being arranged, there was another syncopal episode. And then he was, rather than passing TPM, PPM was inserted at that time. And then he was asymptomatic after PPM insertion. And
Was he being monitored when he had this syncope, or what was his heart rate?
He was being transferred to the theater when he had this syncopal episode. So it was managed by the surgery teams, and then PPM was implanted.
Wow. So on the way to the operation room, he had a syncopal episode.
He had an episode while he was asymptomatic for a few days before that. Maybe something associated with stressor.
Do you know if he was bradycardic during this syncope episode, or
Yes,
did he just
was
spontaneously
bradycardic.
recover?
No, he was bradycardic, and the surgeon told that he has to be resuscitated.
Oh. You know, did they do chest compressions, or when you say resuscitation?
Yes, chest compressions and everything.
Wow. This child is a very lucky child to have, I mean, he nearly died twice.
Yeah.
Let me ask you this. The temporary pacemaker that he had at the very beginning, was that taken out, or was it still there?
It was taken out after a
Okay.
few days. It was
Okay.
not in place when he was being transferred to surgery.
So he
Because
was asymptomatic and doing well, and so that was taken out. So maybe one of the learning
So
points
it
from
was-
this is
that
not to
should have
take
been
out the temporary wire,
very well.
right? Especially if the electrophysiologist hasn't seen the patient. To me, I'll be interested to see what Dr. Aziz and Dr. McCann say, but I would be doing daily ECGs on a child like this. And if that ST segment and those T waves keep looking as bizarre as it is, I would continue to at least keep the temporary wire. I wouldn't take it out until I see real normalization of the ECG. What do you think, Pete or Tony?
Yeah, I think so. And I think, I think there's a lot of parameters to watch for this child. And I think ultimately, if this child was at our institution, and I'm certainly not, being critical of anything that happened. I think this is just in the way of exploring alternate perspectives on a case like this, because there are going to be many, especially when you have, 3 electrophysiologists on the same call. We'll probably say 3 different things, but in my, of course, biased opinion, just being who I am, I would say in a patient like this, we would likely hold on to them in the hospital for long enough that we felt comfortable not putting in a pacemaker to send them home. If we felt that this was myocarditis, and I feel like that's the first thing I thought of when I saw these tracings, we would go the route of steroids and IVIG and look at inflammatory markers, CRP, ESR, white count, and of course, troponins as a surrogate for the inflammation starting to resolve. And until the inflammation was resolved off of immunosuppressant or anti-inflammatory medications, what I would say that the patient should stay in the hospital under close observation. Once the inflammatory response was gone, if that's what this really was, we would watch a child for a bit longer on telemetry and probably just send them home with close follow-up and without a pacemaker. The reason why it's worth exploring that as a thought is a pacemaker in a pediatric patient, as we all know as electrophysiologists, is a non-trivial issue. I think, especially with an epicardial device, even with a transvenous device, you can make the argument that that getting a pacemaker in a patient that's at this age is usually uncomplicated. The issue is that if you're 8 and you're going to need a lifetime of reintervention for a pacemaker, whether it's from lead fracture or generator changes or the like, that's cumulative risk over a very long lifetime. So you don't want to introduce that if you can't. And even if this was, let's say this lasted a year, you're going to be hard pressed to find somebody that's going to be willing to take it out. So once you put a pacemaker in, you're kind of married to that thing. There's no divorce there. And that's something typically a patient lives with. Having said that, I have taken pacemakers out and ICDs for that matter, and people where I didn't think they needed them, but that's a very challenging situation that you'd rather just not be in the first place if you could avoid it. Again, that's clearly biased and just one way of looking at it. I'm looking forward to hearing what Dr. Balaji and McKenna have to say.
Tony?
Yeah, I think that what we'll often do in at least leave like the sheath in the IJ that you put in, and so that you can get the wire out, but you can also get it back in pretty fast. So that's what we've done, and I agree with Pete that if we still don't really know what's going on with the myocardium here. Patient is certainly what I would do.
I think fear is a really good word. I think I would be really afraid of this patient. The other thing I thought that came to my mind is this child clearly has something wrong with his myocardium and his conduction system. Even when he recovered, he still has a bifascicular block. He's got a left axis deviation. He's got right bundle branch block. And if on top of that, something happens to make him go vagal, people can have two things at the same time. I mean, I see patients, for instance, with SVT and anxiety disorder. They have palpitations. Some of the palpitations are SVT, some of the palpitations are anxiety attacks. Similarly, this patient on the way to the emergency, on the way to the operating room, if he was awake, something might have made him afraid and he might have gone vagal on them on the way to the operating room. So it's better to be afraid of these patients and treat them with a lot of fear and care. But, I think I would completely agree with putting a permanent pacemaker in this patient. I think, by the, as they say, the proof is in the pudding. I mean, they've clearly showed that this patient needs a pacemaker and he was asymptomatic after they put the pacemaker in. So I would not dispute that at all. But really, it's still a mystery to me what the underlying disease was. I'm thinking more and more, this is some kind of a bizarre manifestation of COVID and some kind of a inflammatory process after COVID is probably the most likely. We've all seen traditional myocarditis with Coxsackie, echo, etc. This is not the pattern that we've seen. So that would be high on my differential. Next slide. Is there another slide or is this the last slide? Anybody in the audience have, I think it doesn't look like anybody in the audience has seen a similar case with COVID. Yeah. If anybody's seen it, please let us know. It looks like Tony is the only one who has personal experience with this kind of a case. So let's talk about heart block, acute heart block management, etc. Dr. Aziz will do a little didactic now to go over that. Again, audience, feel free to keep commenting on the chat if you have any thoughts or questions while Dr. Aziz is giving his lecture. Thank you.
Can you all hear me?
Yeah.
See the slides?
Yeah.
I will try to swap these here in 1 second. All right, so just to be brief here and hopefully a bit interactive too, I'll run through these slides quickly. We're going to be talking about complete heart block today, both in the acquired and the congenital sense. Just by way of definition, just to think about this out loud, what is the rhythm here? We see that there's PR prolongation, but there's one-to-one conduction. This would just be first-degree heart block, as we all know. And second-degree heart block, type 1, you see that PR progressively prolongs, then blocks, then you have a reset of the PR interval with continued progression. This typically is a benign phenomenon. We see this in pediatric patients very often, particularly when they're sleeping and in the athlete. And then finally, this is a patient of ours who has complete heart block with a wide escape rhythm. This is a 15-month-old with a pretty slow wide escape rhythm at that. This is a patient that ended up receiving a pacemaker. The epidemiology of complete heart block, just dumping the congenital complete heart block into 3 buckets, we see that there's an autoimmune antibody type of heart block, it's idiopathic, and then patients with congenital heart block from structural abnormalities really only comprises the congenital sense, 1 in 15,000 live births, not very common. The autoimmune form typically is a fetal exposure to autoimmune antibodies. 60 to 90% of cases follow that course with SLE or Sjogren's syndrome. Later presentations can occur, about 40% of cases that are rarely associated with autoimmune antibodies. So if somebody has congenital complete heart block, think very highly, be very suspicious that it's autoantibody related. Structural heart problems. We mentioned this patient had an echo, but certainly the right thing to do is to look for structural abnormalities in the patient, like L transposition, where the compact AV node is displaced anteriorly, thus making it thin and fragile. Happens 2% per year rate of heart block. Risk factors there are described: intact ventricular septum being 1, 3 to 5% present at birth with heart block, and then 40% will have heart block by adulthood. The patients with canal defects are also susceptible to heart block. And then there's the septal defect syndromes, Holt-Oram being 1, and the NKX 2.5 variants that have heart block associated with them as well. And those can present later, like in this case, for example. The idiopathic familial congenital heart block is a non-immune response. Typically, patients have normal hearts, and there is a strong familial tendency. This is sort of a diagnosis of exclusion. You've worked through all the other diagnoses, and you don't have a reason it falls into this bucket. What about the acquired form, which is likely what this 8-year-old guy had? Depending on where you live in the US, and I'm not so sure what this looks like outside of the US, but there's tick-borne illnesses that can cause things like Lyme disease that have this classic bullet-shaped rash associated with them. Patients can present with heart block after myocarditis with ST segment elevation that's typically diffuse. And as we talked about, drug ingestion, whether accidental or intentional, can cause bradycardia and in some cases heart block as well. The presentations are somewhat dependent on age. So in the patients with complete congenital heart block, they oftentimes don't present with symptoms at a young age. Factors that influence symptomatology are ventricular rate. Probably the most important one is ventricular rate. What is the escape rhythm and how low is it? Will oftentimes dictate whether somebody is symptomatic. The presence of cardiomyopathy can suggest an autoimmune etiology. And then obviously coexisting congenital heart disease is certainly suggestive. Symptoms are pretty straightforward: syncope, exercise intolerance like this patient had. How do we manage this in the acute setting? We're using our AHA PALS algorithm that says first to establish IV or IO access. If the patient's hypotensive or in shock, that if they're not, that means you have time to monitor, wait, to call for consults. If they are, you can use epinephrine as sort of a rescue drug and repeat it every 3 to 5 minutes. You can use atropine, particularly for the patients where you think it's vaguely mediated. That works really well. And if those things aren't effective, then you can externally pace in sort of the extreme situation like we had discussed. Transcutaneous pacing, just to show you what this looks like. You put patches in the AP configuration, typically for a smaller child, and then you hook it up to a defibrillator box, and the green knobs here on the bottom are how you program for transcutaneous pacing. So you switch this lever to the transcutaneous pacing setting, which is the green, the ones that are down here. And then you can adjust the MAs, which is the output, and also, of course, the rate. And then you look for a capture, just like we saw in the transvenous example. Transvenous pacing, like this patient had, we usually use the right internal jugular approach. It's a vein that's pretty easily accessible in the neck, and we traverse that down to the myocardium. From a technical standpoint, there's lots of different ways to do this. You could do it under echo guidance. You could do it under fluoroscopy. I've seen patients do it at the bed. I've seen providers do it at the bedside with no imaging whatsoever, where you just simply look for ventricular ectopy to know that you're in the ventricle, and you play around with the capture thresholds to make sure that you can capture. This is a temporary pacing device. We can adjust the rate, the outputs of the device pretty simply using a battery-powered temporary generator. When do we permanently pace somebody? There are really nice guidelines for this. Permanent pacing is indicated for anybody with high-grade block that's symptomatic or with ventricular dysfunction, sort of the obvious. Another class 1 is for congenital complete heart block in patients with a wide escape, ectopy or ventricular dysfunction. So generally speaking, is a class 1 symptoms or your ventricles not functioning appropriately or indications. Class 2A are patients with congenital heart block that have a slow average heart rate of less than 50 or pauses that are lengthy. And it's reasonable for patients with congenital heart disease with sinus bradycardia or loss of AV synchrony and hemodynamic compromise as a result. And it can be considered for third-degree heart block in somebody that's asymptomatic that has an acceptable rate, a narrow QRS complex, and normal ventricular function. But again, that's a class 2B. When not to pace, when somebody you think might have something that's transient. So in Lyme disease, you can have pretty dense complete heart block that you can palliate transiently with pacing through the IJ with medications, Isopril, for example. But usually if you wait it out beyond a couple of days, it goes away on its own. You don't have to permanently pace. Most cases of myocarditis are transient, and most cases of drug ingestion are also transient. So just a couple of questions here to close. Which of the following patients would permanent pacing be indicated? A is a symptomatic 5-year-old with complete heart block, elevated troponins, and an escape rate of 25. B is a symptomatic 10-year-old with a 15-second event of complete heart block while micturating. C is asymptomatic 4-year-old with complete heart block, normal function, and a Q restoration of 180 milliseconds. And D is an asymptomatic 12-year-old with heart block and an average heart rate of 52. All right, looks like we have 12 or so responses here that are sort of split a bit. So about 2/3 of you chose A, which is a symptomatic 5-year-old with high troponins and an escape rate of 25. So I just want to highlight that this was a question about permanent pacing, not temporary pacing. I think in a patient like this, they're likely symptomatic and you're likely to have to do something from an intervention standpoint. But this is a patient in example A that's likely to recover completely and somebody that you probably don't have to permanently pace. I was thinking the patient in C, even though they're asymptomatic and have normal ventricular function, the fact that their Q restoration is wide at 180 likely suggests that their escape rhythm is ventricular and probably slow. I didn't put what the rate was because I thought that would be a giveaway, but that 4-year-old probably has a low escape rhythm and likely would benefit from pacing. So I was thinking C would be the answer here. This next one's a bit more straightforward. Which medication is the most appropriate in the treatment of symptomatic bradycardia? A, dopamine, B, vasopressin, C, epinephrine, D, amiodarone, or E, lidocaine. Looks like everybody's getting this one. Epinephrine is the right answer. Amiodarone is definitely not the right answer. That can cause bradycardia. And I think that is it. So complete heart block is rare. Etiologies vary and have treatment prognosis implications. So diagnosing the complete heart block usually is the easy part. Figuring out why and what to do about it tends to be more challenging. Pacing indications are pretty well defined and we can lean on guidelines for those. Not always the case for our patients with arrhythmia disorders in the pediatric population. And we try to avoid permanent pacing if we think it's going to be something that's reversible, as we discussed. And that's all. I'll stop sharing here.
Thank you, Pete. That is very, very nice. Good summary of complete heart block. A quick summary. Any questions, any comments from the audience? Dr. Amna, we unfortunately had a few cases of post-diphtheria heart block with myocarditis 3 years back. The heart did not respond to transvenous temporary pacing. Wow. I would be curious to know how you manage those patients if they did not respond to transvenous pacing. Oh, they did not survive. Okay. Well, diphtheria has pretty much disappeared from our world. I suppose these patients were not vaccinated. I mean, it goes to show that vaccination is still important. And Dr. Sorry, my thing is not showing your full name. 5 cases of complete heart block, mostly sepsis. Yeah. I'd like to know what kind of sepsis they had. You can unmute yourself if you want, or Hannah can unmute Dr. Aung and they can talk, give us some information. One of the nice things about this program is we can all learn from each other because these are very unusual cases. This case certainly was, I don't think I've ever seen or heard of a case like this that was presented. So if you have any other information about those cases, what kind of sepsis they had, complete heart block?
Yes, Professor. Yeah, I have one case of infection of feet. The the child, he is 10 years old,
Uh-huh.
and another case is myocarditis that is secondary to pneumonia, and we have another 5 cases is idiopathic.
But they were all
So, yeah.
septic and they had,
And
when you say
and another
septic, you
case,
mean,
another case is UTI, E. coli infection.
wow. Wow. And these patients they were septicemic, they were bacteremic at the time?
With high CRP and low platelet, and the white blood cell is also high. And
Wow.
he was admitted with high grade fever, 40 degree.
I think when we usually see sepsis in the context, we don't usually see it, I'll admit, but when we see sepsis in the context of complete heart block, we always wonder if there's an endocarditis.
Endocarditis.
Sort of a mass by the node somewhere that's causing the conduction system to be compromised.
Yes, I have my presentation about complete heart block. I have 10 cases because in my ward I have a cardiac surgery. So we have 5 cases for operative and another 5 cases for so far 3 years ago. I made 10 cases.
Wow.
5 post op another is a non-operative. And
Very,
we have
very
5. We have 5 cases with a permanent pacemaker, with a epicardialis and a thrombus with a double chamber.
Yeah. Okay. Wow. Very interesting experience. Thank you. Anybody else?
I was actually gonna, I don't know I was thinking, I don't know the distribution of Lyme anywhere else in the world besides the United States. And I apologize, but during the case, I was actually thinking of Lyme and I have no idea. Is there any Lyme up in Pakistan or any tick-borne illnesses? I just had never learned about that.
Dr. Chowdhury, do you know? Is there any Lyme disease in Pakistan? Anybody from that part of the world, in India, north part of India? I don't know. I've never heard of it.
Yeah, Lyme disease is never heard of this disease in this part.
And then
I think it's peculiar to North America.
Okay. And then I guess just, with the pacing, permanent pacing indications, kind of how I summarize or think about them is basically symptomatic is in almost every permanent pacing indication. So I think that's what Pete was getting at with, maybe the micturition syncope person, but if someone's asymptomatic, they don't really need a pacemaker. Oftentimes we have this discussion with congenital complete heart block in a baby that has an adequate heart rate. Sometimes the neonatal ICU will, everyone's going, oh, when are we putting in the pacemaker? But many people with congenital complete heart block do not require pacing or can go home without a pacemaker at least. So it's really just symptomatic is kind of the best way to think about permanent pacing.
Yeah.
I'm Dr. Amna. I was just telling you about the cases of diphtheria that we had in our hospital. So that was about 3 years ago, sort of just before COVID. And we had quite an outbreak, and most of the kids were only partially vaccinated, not completely vaccinated. And they were from one particular area, most of them. So what was happening was that they were coming in either with the neuropathy or with the myocarditis, the ones that were actually coming to the hospital. So the ones that came in with the myocarditis, I think they had 4 cases in which they had complete heart block. And what happened was they had heart block, but the QRS duration gradually increased during their stay. And that was it went up from about 120 to about 180. And that was when the arrhythmia started and everything, and we put in the pacemakers initially in all 4 patients, but they did not respond. And I'm not really sure why that was. And we tried steroids just to see if we could get any handle on it, but nothing happened. So is there anything that you would advise that we could have done?
Well, we have all sorts of bizarre approaches here, like putting them on ECMO for a while and so on. I don't know if that's available for you, but
We do have it, but that's only for the cardiac surgery patients, the post-op cardiac surgery patients.
I know.
It's not being offered to the rest of the patients at all.
Right. You know, there's obviously, and you know, while the diphtheria toxin gets out of the system, you got to support them in some way. It probably caused some myocardial stunning, that the myocardium wasn't responding to the pacing, no matter what you did. We do have some, I mean, some of us who have been in this business long enough, we have an old Medtronic pacing box where you can use very high outputs and very high pulse widths. And if you, but it's not something you can implant inside the patient. You can use it with temporary pacing. But if you don't have that and you're just using a standard pacemaker and the capture threshold is higher than the output you can provide, really the options are very, very limited in that scenario. I mean, you honestly, I don't know, did you write up your things as a case report? Because I think this is a very, very important case series that you're describing and should be.
No, I did not write them up. We did not write them up.
If you have any tracings and any data, you know, any of us here, whether it's Dr. Makanta, myself, or Dr. Aziz, can help you write this up in the literature.
I'll try and look in the previous record if we can find any.
Yeah, because I think this highlights the dangers of not being fully vaccinated. You know, diphtheria is still it's a lethal disease. I mean, we've all got complacent, right, about these old diseases because of vaccination, but there are still vulnerable populations. Yeah. Thank you for sharing that. That's a very, very, it's a wake-up call for many of us. But if we can help you write it up, please get in touch. And maybe Dr. Makanta, he's already written a case report on this. He can help you with it.
Okay.
Okay.
Great. I'll try and figure out, I'll try and find out some data.
Yeah.
Okay.
Please.
Thank you.
Please do. Well, thank you, everybody. This has been a fantastic session. Most of all, thanks to Dr. Chowdhury for being willing to present this very interesting case. We recognize that, you know, even though we are sitting here in the United States and saying ECMO this and that, you guys are doing amazing work with very limited resources. And really kudos to you for saving this child. So with that, we'll stop and we'll meet next month. Another very interesting case next month. Take care. Thanks, everybody. Have a great weekend.
Thank you.
Bye-bye.